Solving a genital ulcer disease case requires filtering the clinical presentation through two specific questions. Does the ulcer hurt, and are the lymph nodes swollen? 5 major diseases, syphilis, chancroid, Donovanosis, genital herpes, and LGV, dominate clinical rotations and board exams. Before looking at specific lab tests, you must identify the clinical phenotype. We can map these using a 2x2 matrix. We categorize the pain profile across the top and cross-reference it with the presence or absence of lymphadenopathy on the side. Focusing on this binary clinical presentation reduces the initial complexity. It allows you to narrow 5 potential pathogens down to 1 or 2 candidates before you even consider microbiology. Splitting suspects by pain puts herpes and chancroid under painful, syphilis, Donovanosis, and LGV under painless. Filtering by lymph nodes moves syphilis and LGV into LAD present. Donovanosis is the outlier, pairless, with absolutely no true lymphadenopathy. Those pseudobuboes, subcutaneous granulomas mimicking swollen nodes, can occur. The pairing of a painless ulcer with clear lymph nodes is the clinical trigger needed to suspect Donovanosis and distinguish it from syphilis or LGV. To confirm the suspicion, look for the classic lesion. Donovanosis typically presents as a beefy red, progressively destructive ulcer that bleeds easily when touched. The causative pathogen is Klebsiella granulomotor. Microscopic confirmation requires a Giemsa or Wright stain. On that stain, look for Donovan bodies, gram-negative intracytoplasmic cysts within large mononuclear pun cells. The organisms often show a distinct safety pen appearance. Management requires azithromycin or doxycycline for at least 3 weeks or until the lesions completely heal. Connecting this safety pin microscopic finding to this prolonged 3-week antibiotic requirement covers the most specific diagnostic and management facts for the disease. Apply the logic to this scenario. A patient presents with a painful, soft genital ulcer with a necrotic base and highly tender, swollen inguinal lymph nodes. Based on the presentation, is the diagnosis syphilis, chancroid, or Donovanosis? This is chancroid. The combination of intense pain and tender lymphadenopathy fits only the painful and nodes present quadrant of our clinical matrix. We can rule out the other options because syphilis presents with a painless, clean ulcer, and Donovanosis presents with a painless, beefy red ulcer with no true lymph node involvement. Prioritizing the clinical phenotype over pathogen names allows you to navigate complex cases by logic rather than rote recall. Consider this final case. A patient from Papua New Guinea has a chronic, beefy red ulcer that bleeds on touch. Physical exam shows groin lumps that biopsy reveals to be subcutaneous granulomas, not lymph nodes. The beefy red appearance and the presence of pseudobubos point directly to Donovanosis. You should expect to find safety pin Donovan bodies on microscopy and prescribe a minimum 3-week antibiotic course. This comparison table provides a final summary of the 5 major diseases, contrasting ulcer characteristics, node status, and treatments. Note the specific patterns differentiating bacterial causes. Syphilis is painless and clean, chancroid is painful and dirty, Donovanosis is painless, beefy red, and lacks nodes. Relying on these distinct symptom pairings ensures you can navigate even the most ambiguous cases by focusing on the physical findings first.